The topic of this video is a full thickness excision of a plantar corn. The patient in question had had a neurectomy done about 4 years ago by myself. I'm a particular fan of excision of neuromas through a plantar incision, and that's probably a video for another time, but I'll just leave a quick link up to an article I did a few years ago based on results of my work, and I could talk at length as to why I prefer a plantar over a dorsal incision. That said, occasionally I do see a cheeky plantar scar. This particular patient had developed really quite a nasty corn at the distal aspect of the scar, and we're seeing a local podiatrist every few months to have this debrided. So she came back to me and I said, okay, well, let's see if we can remove this via a full thickness excision and see if we can improve the lesion for you. So this is really going to be video 1 of 2. And a few months down the track I'll do a second video to see how she goes. Okay, so Linda, you might just feel a wee scratch. Okay, are you ready, Chucky? 3, 2, 1. How was that? Was that okay?
Yeah.
So I'm just going to... No, don't pull a face. Actually, no, you can, you wear your mask. Now I'm just raising that under a bleb, or raising it on rather, a bleb of Anesthesia. Do you know the Westlife song, You Raise Me Up?
Yeah.
So that's the song. We're raising you up. Actually, so you can walk on mountains after today. So I'm just going to put this. Now, I've already done a little bit of local anaesthetic for Linda. I've done my kind of cheat field block, which is coming from the top of the foot. 3, 2, 1, that's it done. So that was about another 2 mils gone in. So you can see how that's created like a little blanch effect. So I'd already gone in from the top of the foot with my little cheat block. You can do an ankle block for sure, but for Linda we've gone in through. Now I've already taken a couple of clinical shots. You can't see it now, it's already blanched, but we've done a bunion surgery for you here in the past, haven't we, Linda? Which has gone brilliantly. We did a neuroma for her through a plantar incision some years ago, and that's taken away all the pain. But unfortunately, one of those rare patients that developed a bit of a cheeky, callousy, corny thing there, and she gets this taken out by a local pod. So effectively what we're going to do, and you can't see it now, it's all blanched, but the scar was from there to there. And just got this really quite nasty corn within the scar. We don't see too many. Normally see it on patients that smoke, to be fair. So Linda, we're just going to see how numb you are. So how are you at the top there? Any sharpness or cheekiness there? What about on the side?
No.
Here?
No.
Here?
No.
So we put 6-7 mils through the top of the foot. I've used 0.75 narrow pin ropivacaine, and that was the most of it. And then what I'll often do with these in clinic without doing a tourniquet is put this little raise you up Westlife styley, and then that reduces the amount of post-op bleeding because it's like a little internal tourniquet. Just check you're still in camera. No, isn't that brilliant? Somebody's just trying to ring me there. Can we just do me a favour, Chucky? We just turn that X off. I've just got one of the surgeons just trying to ring me. I'll ring you back in a second. That's great timing, isn't it? Alrighty. Normally it happens when I put the video on, is the phone goes or somebody comes in the door. Nice to be popular, I guess. How are you doing, Chucky?
I'm fine.
Just going, so I go slowly, just occasionally you'll get a little slight whoop. So I just go really slowly, although you check obviously the patient's nice and numb. Try not to get my hand in shot. One of my YouTube videos, somebody commented on this week, Linda, that sometimes your hand's in the picture and I can't see what you're doing. And I kind of said, thank you for that. Yeah, I know that. But I need to concentrate on the patient rather than necessarily making the best YouTube video. Tinker. Still, you know, so all feedback's good feedback, right?
Yes. Shows people are watching.
It does, doesn't it? Yeah. The double-edged sword that is social media. So there's our lesions. It's really quite a brute. All right, so we're going to send it off to histo So, Helen, if you can just open this stuff up. Now, don't be blaspheming, Linda. Don't be blaspheming. You can't say, "Oh my God."
Oh my goodness.
Oh my, that's it.
It's huge.
So I'm just trying to check in there and just making sure there's kind of no cheekiness in there. And that's just a little bit, tiny little bit. You see, actually, for that kind of lesion, really not too much bleeding. That's because of the tourniquet. Now, I'm going to put a bit of local pressure on there. This is kind of where you like the little Dutch boy in the dike. Okay, now I'm going to put my finger on there. About 3 or 4 hours. You're not out tonight, are you? Alrighty. And then we'll put a bit of a dressing on. So, spare hands. And what I'm going to do, I'm going to put a bit of a dressing on. Pressure is really the main thing. And then we're going to ask Linda why she came to the appointment wearing white trousers, because we don't want to make a mess on her nice trousers. Alrighty, so we'll get a wee bandage on. Helen, I think we'll stop the video there now, and then we'll do a little. Just before you stop, we're just going to keep Linda in the chair for about 5-10 minutes. Basically, just check that she doesn't have any strike through. So basically, it's a bit of a boring video for the next 5 minutes while we just check that Linda doesn't have any bleeding, because we've just had the lino cleaned, so we don't want to make a mess on the floor. A little bit of compression. Right, Helen, we can adios the video just for a second, and then we're going to just keep Linda in the chair for 5 minutes. So I finished off the dressing, no sign of any bleeding after 5 minutes, and I put some compression on and fitted it with a post-op shoe. As per routine, I send my soft tissue samples off to histology. For this one, I'm just expecting it to come back as pure hyperkeratosis, but there's always a chance it could come back as verrucous in origin. Certainly with the majority of the corn excisions I do, they're really verrucous masquerading as corns. But again, that's a video for another time, and I'm partway through an article with my good friend Belinda Longhurst on corn excisions and what to do. But anyway, look out for the follow-up in a few months' time.